We had the opportunity to sit down with Erin Sowell. She is a palliative care nurse coordinator at 2 local hospitals. We hope you enjoyed the interview, and thank you again from all of us at Care for Seniors.
So my name is Erin Sowell. I have been a nurse for almost 10 years. 9 years of that have been in palliative care, so majority of my nursing career. I work at 2 local hospitals in Ventura County. My title is a Palliative Care Nurse Coordinator, so I work amongst a team of palliative care providers.
So, what is palliative care?
Yeah, so palliative care is a specialized medical care for patients who have some sort of life-limiting or life-altering illness. The goal of palliative care is to really improve the quality of life for both patients and their families. It's usually done in a multidisciplinary approach. So typically, a palliative care team would have a physician, a nurse, a chaplain, sometimes a psychologist or a social worker to really touch every domain of a patient's care and for the family. And the hope is to improve their quality of life while they're still undergoing disease-modifying therapies. So it's different than hospice in that sense because patients can still be getting whatever treatments they're needing. They can still get those treatments, and palliative care supports them through that.
Sounds like palliative care is before hospice, correct?
Yes.
Okay, so what happens is somebody checks into the hospital, they get diagnosed with something, and then that's when you step in. Is it a recommendation from the doctor, or is it requested by the patient? How is that?
Yeah. So it can be either way, but typically, I can just give you an example of a patient.
Sure.
Patient comes in and has metastatic breast cancer, okay, and mets her bones, and having excruciating pain. So the doctor can come in, and oncologist comes in and says, I'm really sorry, the cancer has spread to your bones, but I still have lots of different treatment options available for you. And she could say, well, I would love to do all the treatments, but I'm in so much pain. And then that would be when they could bring in palliative care. And the hope would be palliative care could help manage her pain to improve her quality of life. And then she can actually do better with her treatments because her pain would be controlled.
So you're in charge of pain management.
So usually the physician helps with pain, and nursing can as well.
Okay.
And then oftentimes any patient that has any sort of terminal or life-altering illness, there is going to be psychosocial issues.
Okay.
So it's pain, and then it's support for patients and families and helping them navigate the difficult situation. A lot of what I do as a nurse is listening and really truly getting to meet patients where they're at and helping them, guide them in that process. Psychologist helps them from psychology-wise, how to cope with a hard illness. And then oftentimes there is a spiritual component, and the chaplain is able to help with that. So it really is a whole team approach.
Okay, so within your care team, you have the chaplain, the psychologist, the doctor, the nurses. What do you take care of?
So I, as the coordinator, I get to know the majority of the patients on our service. So I'm maybe not involved heavily in every patient, but I at least know them and know the family dynamics for every patient. And then the ones I really get involved with are usually patients that have, they're going to have complex needs outside of the hospital, and I help kind of coordinate that. If there's children involved, I sometimes help with helping to tell the children. I also can help with symptom management. So I kind of wear all the hats of the whole team.
And you follow them outside of the hospital, or once they leave the hospital, they're kind of done, or how does that work?
Yeah, so it's really unfortunate that none of the hospitals in our county have an outpatient program.
Okay.
So when they are discharged from the hospital, we don't follow them any longer, which there's a huge gap in that for our system. If patients need palliative care in the community, it's through home health. So there's home health with palliative care.
Interesting. So that would be a home health care company would step in and they would have their own palliative care coordinator or nurse or
It's basically routine home health, so a nurse that comes out a couple times a week, but then it can be a little bit extra support. So whether that's for symptom management or goals of care, um, helping the family navigate it, it's just a little bit more than routine home health.
do you work with a social worker
Mhm.
to get that person to where they need to go, or is that put on you?
No, it's not put on me, but I collaborate closely with the case management department, which is RN case managers as well as social workers. So depending on kind of what the needs are, because I've been in the field for quite some time, I just have worked closely with a lot of the different agencies. And so I know what some agencies are capable of helping with. And so if we have a certain complex patient, then I might be able to reach out to a particular agency to help with those needs. So I'm kind of a resource for the case managers and the social workers in that way.
Then how do you know that they're getting the appropriate treatment at home or wherever they may be?
Yeah. Yeah. Unfortunately, there's not like a good system in place for follow-ups in that way. You hope that so when someone's discharged from the hospital, the physician sends their primary doctor a summary of the hospitalization. And then the home health agency is going to be communicating with their primary physician. So that's where you would hope the continuity would continue. I personally, a lot of patients, kind of tug at my heartstrings. So I do follow up, but there's not like an official thing in place.
Personally, on the side, you kind of see how the different hospice care companies or home health care companies are.
Yeah, following up, but then also when they're readmitted. So when a patient comes back to the hospital, so I'm just for the sake of continuity, I'm going to use the same patient we talked about, but it could be applied to any patient. Um, so that first hospitalization that we met her, she was there for pain control. And then she goes home. And then say she comes back and it's her cancer treatment's no longer working. Then it's a goals of care discussion. And so the benefit of early palliative care is that the patients and the families get to know us and trust us. And so when it does come to hard conversations, I'm not a new person walking in having this difficult conversation. They've known me from 4 hospitalizations, supporting them, and they trust. I'm a familiar, trusting face to them.
When you say goals of care, what do you mean by that term?
So, goals of care, anything in medicine, there's benefits and burdens of treatment. So, I'm going to go back to our patient with metastatic breast cancer. She may have recurrent hospitalization after hospitalization for different things related to her breast cancer, whether it's pain related, she's fatigued because of the treatment she's going on, whatever it may be, she may have rehospitalizations. So oftentimes we'll sit down and we have a goals of care discussion. So we talk about these are the treatments that you've been going through. This is the benefit that we've seen, and then this is the burden that we've seen. And so to really understand what her goals are, what she's trying to achieve, and how we can help support those. So sometimes goals of care means continuing on the current treatment path, understanding that there's burdens and suffering associated with it. And sometimes goals of care means transitioning to focusing on comfort and then moving more towards hospice.
Mm.
Goals of care can also include talking about code status, so someone's wishes around resuscitation. And, as their disease progresses and they get sicker, would they want their life prolonged artificially, essentially, or would they want a more peaceful and natural death? Goals of care is also advanced care planning and really talking about big picture goals. So it's goals of care is a very umbrella term and it's very patient specific depending on what's going on with their illness.
When you brought up advanced directives and the different, forms and such that these people have to fill out, do you walk them through it? Do you explain everything? When is this addressed? Is it addressed like soon as they're diagnosed, or how does this process work?
Yeah, in a perfect world, anybody at the age of 18 would have an advanced directive.
Okay.
Um, I think as a society, we're really bad about doing early early advanced care planning. So now if you go into your doctors, you notice that one of the questions on the questionnaire is, do you have an advance directive? Yes or no? And if it's no, are you interested in completing it? I would say that the majority of providers, they're not very proactive with advanced care planning. It's usually um, by like word of mouth. So if a family friend that's like, do you have an advance directive? Or there's a nurse in the family, a friend that's a nurse that knows about advance directives. But I think it's not like, okay, you've been diagnosed with cancer, let's work on that advance directive. That doesn't happen. Advance directives, as I said, they're for anybody 18 or older. If they, regardless if you have illness or not, the main part of an advance directive is who you would want to be your spokesperson. If you were ever in a situation that you couldn't make your own medical decisions, who would you want to speak for you? And then it goes more into like what your healthcare wishes are. So it's very different than a pulse form. A pulse form is for patients that have a life-limiting illness. If the doctor wouldn't be surprised if a patient were to die in the next year, then they're appropriate for a pulse. And a pulse stands for physician's order for life-sustaining treatment. So it's a legal physician's order, and that is more detailed to talk about code status, meaning CPR, no CPR, life support, no life support. Um, so it's a more complex form.
That's a
So
lot.
there's advanced directive and pulse forms.
That's a lot.
Whole segment on that.
I could see that a lot of people don't wanna even think about that,
Hmm.
and I can't imagine being diagnosed with an illness and then turning around and having to think about that.
That's why it's better before, right?
But nobody wants to think about it.
I know.
But it's something that I guess we have to bring, people's attention to, to get it done.
Yeah. I mean, the alternative, which unfortunately we see often in the hospital settings, is a patient comes in altered and they aren't able to make their own decisions. They've never had these discussions with their families. They have no documentation. And then here is the family trying to make these really, really hard decisions without any guidance. And it can be really, really burdensome on the family. And so, honestly, having an advance directive, having a pulse form is a gift for your family that they don't have to guess and wonder because it's outlined for them. And they at that point are their loved one's voice. They're not making decisions. They're their voice just saying, we have it all right here. This is exactly what my mom would want. And I want to honor exactly what she's already told us.
So with these forms, do they need to be notarized? Where do you get these? From the doctor's office, from the hospital? Where do you get these forms from?
So an advanced directive, they're easy to find online. If you just Google Advanced Directive California, you can print them and have them in all different languages. Doctors' offices also have them. So for an advanced directive to be legal, it has to either have two witnesses or be notarized. So the witnesses can't be the people that you're naming as your healthcare agents. They have to be other people. Or you can get it notarized, either or. And then a pulse form, most doctors' offices have them. They're bright pink forms. They're made to stand out. Doctors' offices have them, or you can print them out. Hospitals have them. And how that becomes legal is it has the doctor's signature and then the patient or family member's signature. And I feel like I should have mentioned for advanced directives, the person that is completing it, they have to complete it themselves. Like their loved one can't complete it on their behalf. They have to have what we call capacity, meaning that they understand the document, they understand what they're filling out, and they are signing it knowing what they're completing on there.
Got it. Okay. And then with these forms, do the individual patients hold on to them or they go into their medical files?
It's a good question.
Yeah, how does that work?
So the person should always keep the original, and then their doctor, the primary doctor, any specialist they're seeing, the hospital that they most likely would go to should have copies. Unfortunately, we don't have like a national database that stores all of these documents that you could be accessed from different institutions. It's, hopefully in the future, that's something that is worked out. But right now, it's Keep the original, give other people copies. And then, of course, whoever you're designating as your decision maker should have a copy.
Got it. And so when that person is in the hospital, you talk about these forms with that person or that patient, and then you, if they're not filled out or if they do not have these forms in place, you work with them and work with the family to get those done?
Yes. I actually find that using those forms as a conversation guide is really helpful. And sometimes I'll even bring a couple to the patient's room and, like, let's have a family activity in here and everyone does it, because then it takes a lot of the pressure off of the patient and the severity of what's going on with the patient. And it kind of normalizes the discussion. Like, we're all doing it together. It's something we should all have. Let's do it. And in that, you can learn a lot about, what the patient's goals and hopes and wishes are, without being so scary.
So when someone is diagnosed with a disease process, uh, is it requested by the patient? Do they have to request palliative care?
Yeah, I would say very rarely are we requested by a patient or family. Um, One, people don't know what palliative care is and they don't know what to even ask for it. And then two, if people do know what palliative care is, they have a misconception that it's actually hospice and end of life care. So most people aren't asking for that. Um, we've actually trained the different doctors that we work with to please not ask the patient and family if they want a palliative care consult, because it can be more harmful in that way. We feel like us coming in and introducing ourselves is better because it's like the first impression. And I don't walk in the room and say, I'm one of the palliative care nurses. Typically, I walk in and say, Hi, my name's Erin. I'm one of the nurses here on a support team. I'm not here with any agenda. I just want to get to know you, what's important to you, and how can I help you? And usually, just sitting down and listening to someone, it's just really amazing what you can learn and how you can help. And I find that going in with no agenda like that, um, I actually have much better outcomes in my discussions because patients sense that. If I walked in like, oh, I really want to talk to them about code status, I really want to find out what their goals are today, a patient's going to feel that and, being guarded.
So how do you break that barrier to people that like palliative care is not part of hospice and it's here to help? We're not here to push you to hospice and to go on and
This graph is really helpful to show at time of diagnosis, the hope would be that the intent for curative treatment or good treatments, maybe not curative, but life prolonging treatments, that there's lots of treatments available for patients, and maybe the role for palliative care is really small. As the disease progresses, unfortunately, the likelihood is there's less and less treatments available. And this is true for any disease, whether it's a cancer, whether it's a heart failure, if it's a lung disease, dementia. As the disease progresses, the treatment becomes less and less. And so the role for palliative care becomes more and more. And it can be for any of those reasons, whether it's symptom management, goals of care, extra support, all of those things I previously spoke to, those roles become more and more. Once the patient reaches the point where there's no more disease-directed therapy available, that would be when they would transition to hospice. And what we find is actually that whether it's denial, as you mentioned, denial on the patient's end, or often it's actually on the provider's end that they're afraid to, for whatever reason, offer hospice, it actually does a disservice to patients, because patients who go on hospice sooner, they do better. I mean, that there's research to support that, because they're oftentimes home, they're comfortable, they're not going back and forth to the hospital, being poked and prodded, beeping alarms. They're getting hopefully good, better quality sleep at home. So there's something to be said about, earlier hospice than waiting till the last week of their life. The hospice benefit is technically for patients who have a prognosis of 6 months or less. And so patients can be comfortable for months and months at the end of their life, having quality time with their family. And instead, we do this disservice to them, give them false hope, a kind of dangling carrot that, like, maybe if we can just do X, Y, and Z, I'll have one more treatment for you. And if as soon as someone hears that, they're going to try that. Most people would try for that. And what isn't explained is to get X, Y, and Z, it's going to mean you're going to spend days and days in the hospital. You're going to be nauseous and pain, whatever it might be. Um, and so I think that we all, like, collectively as a healthcare system, need to be better about being transparent with our patients, having honest discussions. And it really is that true informed consent.
When it comes to a diagnosis and the patient does not want to seek curative treatments, do you step in to help empower that patient against the the medical community?
Yes, I am all about patient autonomy and will always support a patient where they're at, whether that's wanting treatment or not wanting treatment. Informed, to me, if a patient's informed and making an informed decision, then it's our obligation to meet them where they're at in that journey. And even if that means not doing the treatments, there are some physicians who have a really, really hard time with that and just need the reminder of, no, it's their right. They get to choose, and we need to support them in that.
So you're fully behind the patient, no matter what the decision is.
100%. Yeah.
That's good.
Yeah. Even if the patient is making a decision that could potentially be more harmful, and, like a patient who has a terminal illness that still wants CPR. It's like we don't want to do that to them because we know that it would cause them more harm. But if a patient in their right mind is fully understanding and they still want to do it, I will. I will always support a patient in their decisions and not try to persuade them away from that.
When it's time to discharge a patient, what does that look like? So you're at the hospital with them. What's the conversation?
Yeah, so it really goes back to what their goals are. So if a patient's goal is, physical therapy is saying that they are safe to go home and their goal is to continue with treatment, then home health with palliative care is a good option because then they could get physical therapy, occupational therapy if they need it, and then they would have palliative care to help with their symptom management.
And that's done through a home health company. Got it.
Yeah,
Okay.
not us.
Correct.
It's all through a home health company. So that's if the goal is to continue with treatment. If a patient's saying, you know, I I hear that the doctors are saying that maybe down the road there could be another treatment, but I'm tired. I want to be at home. I want to be comfortable. Um, I don't want to be poked and prodded and any of those things anymore. Then that would be when we would arrange for hospice. So it really, what the disposition plan is kind of dependent on one, their functional status, and if they're safe to go home, or do we need to look for like a skilled nursing facility, um, or a boarding care, depending on the situation. So one is their safety of going home, and then two, what the goals are.
Thank you so much for sitting down with us. Really appreciate it. I learned a lot. Hopefully, it was able to help a lot of people.
Yeah, thank you. And I'm happy to be a resource for anyone needed.